We have two interesting cases lined up today, one from Cape Town, South Africa, and one from Machakos in Kenya. So great thank you and a welcome to our presenters as well for today. Just some house rules before we start. The first is just to kindly register using the chat function using your name, institution, country, and email address. The second is just to kindly just keep your microphones on mute throughout the presentation. And lastly, if you have a question, you have two options. The first is to just type in your question using the chat function. And the second is to unmute your microphone, raise your hand, and then go ahead and ask it when I give you the cue. So without any further ado, I'd welcome Dr. Kate Wright, our first presenter, who's a registrar at Stellenbosch at the Tygerberg Hospital in Cape Town, South Africa. Dr. Wright, please go ahead. You can share your screen.
Thanks, Tazio. Okay, is it up?
Yes.
Okay, great. Well, thank you so much for this opportunity. As Tazia said, I'm a registrar at Tygerberg in Cape Town in the ENT department. So I'm going to start off that I've got written consent from my patients to share their information on this platform. I've got no conflicts of interest. I've referenced all the information, and I'll give permission for this presentation to be shared. I'll start off with Mr. JF, who was a 69-year-old male who presented to our head and neck clinic. He came in complaining of a 6-month history of hoarseness and a 1-month history of stridor. But he had no otalgia or other pain and no adenodysphagia. So at this point, I thought he was a fairly run-of-the-mill head and neck patient, possibly with a glottic lesion. He denied any weight loss, but had a 40-pack year smoking history, occasional alcohol use, and he had no comorbidities. He had a good functional status. On examination, he was quite thin, despite him denying that he had lost weight. And he had quite marked inspiratory stridor. However, he was not distressed, and he was able to speak and exert himself quite well. He did, however, have quite a hoarse voice as well. And on neck exam, he had clinically no lymphadenopathy or other masses. On oral exam, he was edentulous. The exam was otherwise normal in the oral cavity. And of note is that he had no improvement of his stridor with adrenaline nebs that we gave him. Unfortunately, the flexible scope picture, the video that I took, has been lost with some equipment that was damaged, but we saw a mucosal covered mass in the supraglottis, which was involving the left aryepiglottic fold and the vallecula, obscuring the left vocal cord and crossing the midline. So at this point, I was just wondering if anyone would like to give some options of what the differential diagnosis is, and just what out of the ordinary in this patient doesn't make you think that it is necessarily a malignancy. I don't know if anyone wants to volunteer. Otherwise, I can see, is that Simon hiding in the corner there?
Hi, Kate. Good to see you again. Yes, it is me. I think squamous cell carcinoma would obviously be the most common diagnosis in our context in this description of the patient. But yes, like you said, it might also be other benign conditions such as TB or other less common malignancies, Kaposi's sarcoma, but it doesn't really fit the clinical picture.
Okay, great.
But I volunteer the possibility of a Laryngocele.
Thank you, Prof. You may. Great. So yeah, as you mentioned, Simon, we obviously have to have carcinoma of the larynx as a high possibility, as well as other less common cancers or malignancies which also present with much more of a submucosal swelling, so such as intralaryngeal plasmacytoma, lymphoma, a minor salivary gland malignancy. And then within the benign lesions, we're most likely thinking of a laryngocele or possibly a lateral thyroglossal duct cyst, other saccular cysts, or a cystic schwannoma. So this was the CT scan of our patient in the coronal view, and here I've outlined the homogeneous cystic swelling that was found. And of note in this view is that it is medial to the thyroid cartilage, but it can be seen quite clearly crossing the midline and partially obstructing the larynx. On this video here of the axial scan, I'll stop it there. I just want everyone to note that there's a cystic component as well as an air component, and that it is quite well defined by the thyroid cartilage in this case. And that it is not extending out into the neck in this patient. So in fact, we did diagnose this patient as having a laryngocele, and we couldn't see any evidence of malignancy on the CT scan, and his symptoms of having no pain or neck nodes also just helped to reassure us. So does anyone have any thoughts on the management options for this patient? Tazia, do you want to maybe help us out with some options?
Sure, Kate. So my question was that, so does this patient have a laryngopyelocele as well? Is this patient septic?
No, he didn't present with any fever. As I said, he didn't have any pain. His blood results didn't show any raised septic markers.
Okay, because the definitive plan for laryngocele will be excision. There are options in ways in which you can excise that laryngocele, whether it's an open lateral cervical approach or a endoscopic approach. So that's the definitive management. But at this point in time, if the patient doesn't have a laryngopyelocele, you can directly move there. But otherwise, you would ideally want the infection to settle. There is a needle aspiration that's been described to wait for that time and then treat with antibiotics, aspirate, and then once that patient is sort of baseline stable, and then go into the incision.
Yeah, exactly. So in this case, because we weren't concerned about a pyocele, but because the patient was quite stridorous and uncomfortable, we took him to theatre fairly soon and performed an endoscopic excision of the cyst with cold seal and suction diathermy. As you can see on this initial picture, just to orientate you, this is the patient in suspension, and there's a slither of the vocal cord on this side. Possibly better on this picture is the aryepiglottic fold. And the left side of the vocal cord is completely obstructed. This is before we had started the surgery, and you can see that it's covered in mucosa. And then once we had started to separate the cyst from the mucosa, this is what this picture shows here. This video is just before that second picture that I just showed you. So in this case, we are just grabbing the mucosa of the larynx and using scissors, cold steel, to find a plane between the cyst and the mucosa. And as I mentioned, because there was no evidence that it had been infected before, we were able to find quite a nice plane to excise the cyst. In this case, just going slowly, controlling bleeding as you go, and then making sure that you get around the cyst on both sides and get the cyst out, if possible, in its entirety. This is a photograph near the end of the procedure. There's still possibly some of the cyst tissue left that still needed to be removed and some evidence of cautery. But you can now see both vocal cords. There is on this side, some atrophy of the vocal cord, probably from the laryngocele end of the procedure. Post-operatively, the stridor resolved immediately, and the hoarseness had improved quite a lot by the next day. The patient was discharged home without event, with a referral to see a speech therapist. At his 2-month review, he had no symptoms that he was concerned about, and there was no evidence of any recurrence. The histology showed a respiratory type mucosa with features of chronic inflammation, and it was absent of any malignancy. So just to review the anatomy of this area, the ventricle is the area that we're concerned about. And this is the fossa between the true vocal cord and the false vocal cord. And this ventricle leads superiorly to form the saccule. The saccule is thought to function to secrete and lubricate the vocal cords. Now, a laryngocele is when you get an abnormal dilatation of the ventricle and saccule, which is in communication with the laryngeal lumen, which is why you often see air in the laryngocele. In contrast, a saccular cyst is also an abnormal dilatation of the ventricle and the saccule, but there's no opening into the larynx, and therefore it is always filled with mucus. Just to show some better pictures here, we've got a picture of a laryngocele, which then has the potential to expand and obstruct medially and expand into the neck, whereas a saccule is often more anteriorly placed and, as I said, is not in communication with the larynx. There are a number of different classifications of saccular cysts, and it can become quite a confusing classification system, but I just wanted to sort of simplify it a bit into some broad groups. We generally have ductal and saccular cysts. Your ductal cysts are essentially mucus retention cysts that can occur anywhere, and so they can be found in the ventricle, in the epiglottis, in the vallecula, and they are sometimes thought to be responsible if they become infected for example, adult epiglottitis or other unusual infections in these areas. In terms of saccular cysts, as I mentioned, the ones that are not in contact or open to the larynx are classified to anterior and lateral. And then we have our laryngoceles, which are classified into internal and combined. Literature also does refer to internal as type 1 and combined as a type 2. Previously, there was a third classification, which was an external laryngocele, but it is generally felt now that in the case of an external laryngocele, there is always an internal component. And so more recently, it has been described that these laryngoceles, that external component, are actually always combined. So just to go into a bit more detail, again, the anterior and the lateral saccular cysts. The lateral saccular cysts are generally the congenital cysts that you might find, and these are always filled with fluid. Whereas, like I mentioned, the laryngoceles will have air. They sometimes have fluid as well. If they're full, the air might have been pushed out, and there might be pus in the case of a laryngopyseal. The saccular cysts, they herniate the saccule into the larynx, but are not open to the larynx. However, the laryngoceles communicate with the larynx. And then lastly, the anterior saccular cyst, like in this picture, generally protrudes between the true and the false cords, whereas the lateral saccular cyst extends more posteriorly and superiorly into the false cords and up into the aryepiglottic folds. A laryngocele then, obviously, like I mentioned, will be internal or combined. I'll go into more detail of that. So an internal laryngocele, like in our patient, extends superiorly and laterally into the false chords and the aryepiglottic folds. And it may also bulge into the medial wall of the piriform sinus or molecular if it gets very large. In terms of a combined laryngocele, this was another patient that we had. So the internal component will extend as I described for an internal laryngocele, but it will then extend upwards and protrude through the thyroid membrane into the neck. As can be seen here, there's quite a large gap between the hyoid and the thyroid, if we compare it to the contralateral side, where the cyst is extending. All types of laryngoceles are covered with pseudostratified columnar epithelium. And there is theory in the literature that because these cells are fairly well protected within the saccule, that they have less exposure to carcinogens such as smoking, and therefore that there is very seldom metaplasia that occurs. We mentioned earlier the differential diagnosis for an internal laryngocele. Just to go over for a combined, obviously this may present with a neck mass. So in this case, you might have a branchial cyst as your differential, a neck abscess, lymphadenopathy, again, a lateralized thyroglossal duct cyst. There's obviously many more differentials for a lateral neck mass, but in this case, it is going to be a cystic mass that is generally non-tender unless it's infected, and may also expand with increased glottic pressure. So there are three main theories as to the etiology of laryngoceles. Either congenital factors, increased laryngeal pressure, or mechanical obstruction. In terms of causes, for a long time it was believed that increased pressure in the glottis in certain professions, such as trumpet blowing or glass blows, was thought to be a risk for laryngoceles. However, it's been found that there's not necessarily an increased incidence in these professions. So it's questionable as to whether it really is an increased risk. Most of them seem to be idiopathic. As we've mentioned, that laryngeal carcinoma always needs to be excluded in these patients. The reported incidence is between 4.9 to 28%. And it's been suggested in the literature that these are called pseudolaryngoceles because in fact, it is the tumor that is blocking the saccule and therefore causing the laryngocele to form, that it's not a true laryngocele. Cystadenomas are also a very rare cause. The presentation obviously depends on the location and mostly are asymptomatic. In fact, the prevalence is a lot higher than the patients that present. And this is evidenced by CT scans that are done for other reasons where laryngoceles are found incidentally, as well as in a lot of cadaveric studies. Hoarseness is the most common presentation, and then increasing order, stridor, dysphasia, just a sore throat, snoring, or a cough are the other most common complaints. They can occasionally be bilateral, and as Tazia mentioned, they can present infected as laryngopiaseals, and this is 5 to 8% of laryngoceles that present will be infected. The diagnosis on neck examination, you might feel a mass that's palpable at the level of the thyroid membrane, and this may increase if you ask the patient to valsalva. And then again, on flexible nasendoscopy, it's obviously quite an obvious submucosal mass that is seen. CT scan is normally adequate to diagnose a laryngocele. It shows if the cyst contains air and fluid, as well as showing it in relation to the thyroid membrane. Obviously, an MRI will also be effective in showing it. And it may be helpful if there is concern of a tumor or if there's previous infection in the area with fibrosis. It may be helpful to do an MRI, but it's seldom required in your typical laryngoceles. So in terms of the management, as Tazia mentioned, for a pyolaryngocele, you need to treat with antibiotics initially and allow the infection to settle. and to consider a tracheostomy in a threatened airway. These tracheostomies are reported much more in the literature in laryngopioceles, but they may also be necessary for laryngoceles that are not infected if the airway is threatened. In terms of an uninfected laryngocele, the urgency depends on the symptoms, but it's reported that 10% present as airway emergencies. Aspiration of the cyst is only applicable in the acute setting in order to save the airway, but the laryngocele will occur, and this is not a definitive treatment. As we mentioned, there are endoscopic and open procedures depending on the expertise and on the laryngocele. So to go over the endoscopic approach, this is performed for internal and sometimes it is mentioned for combined laryngoceles. The patient is put into suspension and microlaryngoscopy is performed. The sac can be marsupialized, and this can be done with cold steel microdebriders mentioned. However, possibly with a lot of care. Also, a CO2 laser has become quite popular to marsupialize the sac as well as suction diathermy. Or you can excise the sac also with cold steel or a CO2 laser. There is concern about recurrence of a laryngocele if it is marsupialized. As it's healing, it can close up again and recur. So it's generally accepted that excision of the sac is preferable. And more recently, endoscopic robotic surgery is being used to excise laryngoceles. It should be mentioned that you should consider an external approach if there is any recurrence. And just to talk a bit about doing combined laryngoceles via the endoscopic approach, it is obviously more risky. The literature that mentions it, they talk about excising the sac initially and then trying to grab the sac from where it extends through the thyrohyoid membrane. But obviously if there's any concern, that it would rather be preferable to do an external approach. Patients report very good phonation post-operatively. They have a minimal hospital stay. So if it is possible, it is a very nice procedure for the patient. Report good phonation post-operatively and have a minimal hospital stay after the procedure. In terms of the external approach, this is mostly done for combined laryngoceles. A lateral skin incision is made over the thyrohyoid membrane. There are 3 types of procedures that are described with these, with the external approach. The transthyroid membrane approach, which is by far the most common approach used. And then there are 2 approaches that are used to address the thyroid cartilage. This is a thyrotomy with resection of the upper third and a V-shaped thyrotomy. A thyrotomy is normally done if exposure to the paraglottic space is required. But in the literature, as I mentioned, it's most likely the transthyroid approach which is used. It is important to preserve the superior laryngeal nerve as it is at risk during this procedure as it pierces the thyrohyoid membrane. These patients have a slightly longer recovery post-op than the endoscopic approach. Just to briefly address pediatric laryngoceles. Duplication cysts, hematomas, aureostomas, and teratomas. And that the treatment for children would be the same approach to whether it's internal and external. The patient might need to be intubated quite soon in order to secure the airway and then to proceed in the safest possible manner to treat it. Thank you for your time. These are my references. Are there any other questions or comments?
Thanks very much, Kate, for that presentation. Very, very interesting. I'd like to open up the floor now for any comments or any questions. Professor Fagan, any comments from your side?
Okay, thanks very much. That's a very nice Nice summary and presentation, also a nice case to present. Yes, I mean, these aren't very common procedures, you know, so one doesn't see them very often. But I must say, you know, the internal laryngoceles, if they're small, then I'm certainly excise them, but otherwise I just widely marsupialize them using CO2 laser. And so far I haven't had any problems with recurrence because they're very wide open area that you expose. And it's always a matter of weighing up the damage that you do to the laryngeal structures if you try and excise it as opposed to marsupializing it. You know, so I think one has to individualize that based on the size of the sac, as you pointed out.
Yes.
Yeah, and just in terms of external approaches, just remember that one can reset the whole one thyroid lamina without causing any functional problems in terms of laryngeal function. So as you pointed out too, to get access with the external approach, one can resect the posterior third or half of the thyroid lamina to get access to that paraglottic space.
Okay.
But a very nice presentation. Yeah.
Thanks, Prof.
Thanks very much, Professor Fagan. Perhaps Dr. Kenneth Baidu, any comments from your side on how these patients are managed in West Africa?
Good morning. Thank you very much for a very nice presentation. Actually, I'm doing a case on Tuesday, which looks like it's a laryngocele in a pediatric, a 6-week-old child. This is like God-sent review of what I have to do. And with this, about the fourth I've seen in the last couple of years. And it represents similarly like you have described. And most of the time we approach them. I remember the last one we did external approach because it seems a little too big. Otherwise, we try to address them endoscopically. So thank you very much for giving me a head start on what I'm going to do on Tuesday. Congratulations.
It's a pleasure and good luck.
Thanks very much, Dr. Baidu, and good luck for your case. Professor Sidat, any comments from your side from Bloemfontein?
I think it was a very good presentation. Okay, it's not something you see very often. I think she covered the topic very well.
I could ask Cheikh Macharia to comment from Kenya.
Thanks, Prof. Excellent presentation, Dr. Wright. No comments from me. That was a really good review. Thank you.
Kate, there's a question on the chat function. So the question is that should we be concerned about malignant transformation, and is there a place for conservative management?
Yes, you should. Well, probably not be concerned about necessarily transformation, but we always need to be concerned about a malignancy that's causing the laryngocele or possibly hidden by the laryngocele. There is a role for conservative management, although it would more be conservative monitoring. There's not much necessarily management you can do conservatively. And as I mentioned early on, a lot of laryngoceles are asymptomatic. So you wouldn't necessarily treat them if it was found incidentally and the patient didn't have any symptoms. However, if there are symptoms of hoarseness, and especially stridor, it would probably be in the patient's best interest to treat it. As opposed to not.
Professor Fagan, any comments or any replies to that question as well?
Yeah, I think as Kate pointed out, it's an unusual association of malignancy with these cysts, but certainly one should be aware of it, and I think her comments are absolutely spot on.
Okay, thank you very, very much for everyone who's participated in this case. Kate, any closing comments from your side, and then we can move on to our second case.
No, I'm good. Thanks, Tazia. Okay,
great. Thanks once again for your presentation, Kate. I'd like to now invite our second presenter for the day, Dr. Ian Macharia, who's a consultant in the Machakos County Hospital in Kenya. He trained at the University of Nairobi a few years ago, and he's now been practicing in Machakos. Dr. Macharia, it really is a privilege for you to join us. Please go ahead. You can share your screen and kick off.
Okay, asante sana Tasir. Thank you. So let me share my screen. Just start now. Oh, okay. So you can see that?
Yes, yes.
Okay, perfect. So as Dr. Tasir said, my name is Dr. Macharia. I'm an ENT surgeon at Machakos Level 5. And I'm going to present adenoid cystic carcinoma. I got written consent from the patient and I don't have anything to declare. So this is going to be my case outline. I'm going to have the case presentation, discussion, and then I'll share my references. Machakos, that's my hospital. It's about an hour drive from Nairobi. That's our capital center. We are 2 ENT surgeons, myself and Dr. Kerosi. We just finished last year. And the good thing is we have a mentor surgeon from Aga Khan. He's a head and neck, so definitely helps us. During this COVID period, we've gotten about 8 theater days, but before we used to have 4 theater days. And half of them are dedicated to head and neck cancer care. So that's the context that I work in. So let's just go direct into the presentation. So I'm presenting DK. He's a 70-year-old male retired lecturer. And his history started 16 years ago with dysphonia. And he said it progressively worsened over an 8-month period when he finally sought care. He did not have any stridor or any dysphagia, no digestive compromise, and he denied any smoking or alcohol intake. I don't have much information because all I had was a discharge summary. So what they did, they took the patient to theater for direct laryngoscopy and microlaryngeal excision. And what they found bilateral cord mobility. However, they found a firm mass on the left ventricle, which was removed. I don't know the details of that, as I said, and I took it for histology and negative for malignancy. Okay. Now, he again presented 1 year ago. Now, still not to a hospital, but a different facility with persistent dysphonia. He had dysphonia the entire period. This time he had progressive respiratory distress. He did not have any dysphagia. He still denied any smoking or alcohol, and he didn't complain of any chest complaints. What they did was a CT scan, chest X-ray, and an MRI of the neck. I don't have any information about the scope. So the CT scan showed a 5 by 3 by 3 centimeter transglottic mass. Spanning from the preepiglottic up till the subglottic space, the pneumocosal ulcerations. Laryngeal still was noted, and level 2B nodes were also noted. So these are the coronal CT scans, and you can see for sure there's laryngeal compromise. And when you look at the sagittal scans as well, he definitely, you can actually see it going all the way up to the preepiglottic space. And when you take a look at the axial scans, you can see that there's eccentric narrowing of the airway. However, the laryngeal cartilage is intact, even with this particular scan as well. But you can see that it's actually enlarged. An MRI, tier 1 was done, and this is just 3 different views: sagittal, coronal, and axial. This is post-contrast, and you can see it's slightly enhancing. It's just giving us the same information, and this is the MRI T2. Okay. Now, we also did a chest X-ray This is important for all laryngeal masses, and we did not see any pathology, okay, or any metastasis. So a direct laryngoscopy was performed. From the notes, what they found was a bulge within the larynx, a submucosal mass in the left vallecula, extending and then having medial displacement of the left arytenoids, the false vocal cords, and the true vocal cords. However, the base of tongue, epiglottis, arytenoids, aryepiglottic fold, and the right side normal. Multiple biopsies were taken at different time points. Remember, this is 1 year ago. And about 5, and consistently they came out benign squamous epithelium. Now, this is odd because of, you've seen the CT scan, you see an obvious laryngeal mass with respiratory distress, and what you expect is squamous cell carcinoma or something malignant, but all showed benign squamous epithelium. So finally, a suprahyoid laryngophagia was performed, and a biopsy was taken. They found the mass, took it, and what the biopsy showed was adenoid cystic carcinoma. Now, so surgical plan was a total laryngectomy for the patient. However, due to increasing COVID pandemic, we have not yet hit our peak, but our cases are rising exponentially. It derailed the plans of the total laryngectomy in the National Referral Facility. So what happened was that the patient was referred to us about 2 weeks ago, and we actually did the total laryngectomy 2 days ago. That was Wednesday. We did a TL with bilateral selective neck dissection, level 2 to 4, and a left lobectomy. He's currently post-op day 2. He's doing well. Post-op day 1, we standard take our patients to ICU, just because of we're sure about the care they get in post-op day 1. He's currently doing well, surgical site intact, stoma well, drains active, draining about 100 ml, and he's doing very well. Okay? He's now in the ward. This is our, what do you call it? Those are surgical markings. On the right, you can see the specimen. And here, this is the specimen. And if you take a look at it, I cut it into half. I did a posterior sagittal cut. And if you take a look at the specimen on the left side, you can actually see the mucosa is intact. At the very top, the epiglottis, where it looks ulcerated, that's where we grabbed it with an Alice forceps. So that's where it looks off, but that was not there pre-op. But you can definitely see the mucosa in is intact. You can see a definite mass, and then you can see it peeking beneath the vestibule. Okay, so I suspect that the reason the multiple biopsies were coming out as benign epithelial was because it was actually being taken from the squamous epithelium rather than the submucosal mass. Okay. So anyway, as a discussion, this is actually a very rare tumor. Adenoid cystic carcinoma is obviously we've not gotten the full histology yet. It'll take about 2 weeks' time, but this is a very rare tumor. It's primarily a tumor of your minor salivary glands, and in terms of head and neck cancers, it counts about less than 1%. And in terms of laryngeal cancers, when I looked at the literature, actually, in the English literature, there have been about 81 cases that have been documented as of 2018. As I said, it's a tumor of the minor salivary glands. However, the thing is that within the entire digestive tract, you have minor salivary glands. And in the larynx, the majority of these salivary glands are in subglottis. But for this particular patient, if you saw the tumor, it was actually supraglottic. Tumors of the minor salivary glands are usually malignant. Actually, the most common is adenoid cystic. Among the major salivary glands, which is your submandibular, your parotid, and the sublingual, the smaller one, the submandibular and the sublingual, is the site of preference. In terms of the growth pattern, we have 3 growth patterns: tubular, cribriform, and solid, and this impacts on prognosis. And there's frequent perineural invasion. When you look at the epidemiology of adenoid cystic, You have a male to female ratio that is equal, and the average age is about 58 years of age. When you take a look at the clinical features, it will present like a laryngeal mass. So, however, the thing about adenoid cystic is that it's very slow growing. So you do get your hoarseness of voice slowly. You might get your laryngeal compromise, like this particular patient. For 16 years, he had dysphonia. Then eventually, it became stridulous. They have frequent perineural invasion. This is a key fact about adenoid cystic. And in terms of the survival, it's very key that it has a very good short-term success, and short-term meaning 5 years. Okay, about 70% of patients actually live the 5 years. However, long-term failure does occur. About 30% are not able to hit 15 years. And the long-term failure is a recurrence locally and distally, versus squamous cell carcinoma, where you have local regional failure. For adenoid cystic, it's local and distant, and the lung is the most common site of metastasis. And once you discover metastasis, your median survival is about 13 months. Okay? So that's very key. When you look at the prognostic factors for this sort of patients, you have to look at tumor size. Advanced tumor size definitely is poor prognosis. If there's any presence of lymph nodes, they don't invade usually the lymph nodes, but if they do, then that's a poor prognostic factor. If you're not able to get margins, when you take a look at it under the microscope, a high mitotic rate gives you a poor prognosis, and a solid architecture. And as I said, there are three growth patterns. Tubular is the best, cribriform is medium, and solid is the worst. And actually, some of the ways to classify according to like Spiro or and Santos is looking at the percentage, whether solid is present or absent. That was according to Spiro. But then also Santos talks about the percentage of solid that is there. Is it 0%, 30%? Great. Other sort of prognostic factors that have been looked at, but not very well defined, of course, old age. If you get a sinonasal adenoid cystic carcinoma, if you do have lymphovascular invasion, which is rare, but it's possible, a high-grade transformation, which is extremely rare, and intraneural spread. Because when we talk about perineural spread is bad. However, you can invade the perineurium and spread along the perineurium, but not invade the actual nerve itself. And if you find intraneural invasion, that is the worst, because you can have perineural inflammation, perineural spread, or intraneural spread, or intraneural invasion. What sort of differentials do you sort of get for these particular cases? Obviously, adenoid cystic is rare, so that's it already is a differential for more common laryngeal tumors, as Kate even said, for laryngocele. However, by itself, because it's a biphasic, when you take a look at it, there are two cells. You have ductal cells and myoepithelial cells. So then epithelial, myoepithelial carcinomas can be a differential, and basal cell adenocarcinomas are another differential due to they both have biphasic patterns. When you look at its growth pattern, which could be tubular, cribriform, and solid, then a differential for that is polymorphous adenocarcinoma. And when you look at the literature, you'll actually see that adenoid cystic carcinomas of salivary glands have been cut into half because of polymorphous adenocarcinomas, which have been taken up. If you look at basiloid squamous cell carcinomas or HPV or oropharyngeal squamous cell carcinomas, they may have adenoid cystic-like areas that could be a differential. What treatment options do we have for this particular patient? Well, it is a cancer it is a cancer within the larynx. So surgery, a total laryngectomy is the way to go. However, there's always been a sort of concern whether we need post-op radiotherapy, or should radiotherapy first be implemented, especially because of the risk of perineural spread. However, it's relatively radio-resistant, so that's why it's been thought that surgery is the plan of choice. and then you give post-op radiotherapy depending or individualized depending on what the histology shows of the particular patient. One of the big things is distant control, because it usually doesn't spread to the nodes, but what you have to be careful about is the lungs. And how do you treat the lungs? Do you give radiotherapy? Do you give chemotherapy for that? Because there are very few cases, it's on an individualized basis. So what controversies are there that I found? Number one, how to classify this particular case. I mean, if you classify it according to, for this particular case, the clinical stage was T3, N1, M0. That was according to, if you classify it according to a salivary gland. But if you look at laryngeal cancer, well, it still stays the same, but you know those are different, what do you call it, cellular structures. So should you classify it according to its site of origin, or should you classify it according to the salivary gland classification? There's a controversy about adjuvant treatment because of the short-term success that we have versus the long-term recurrence. So what should you do about it? The thought is that individualize your treatment. What should we do about distant metastasis? We are very keen on doing the chest X-ray on this particular patient. However, from the literature that I actually read, that some entities actually look, some people actually look at distant metastasis like a separate entity, meaning that your aim is to achieve local control and deal with distant metastasis differently. So if there was what do you call it? If there was metastasis, would we still have continued a total laryngectomy in this particular patient? I don't know. And then finally, in terms of long-term recurrence, how do you follow up these patients? How long do you follow them up, or do you follow them lifetime? Some case series have had up to 20 years follow-up. They've had 20 years follow-up. Some have had 15 years. Some have had 10 years. So how long do you follow them up for, and how do you follow them up? Like, how do you periodically examine these particular patients? So, so that's what I got for my case. Those are my references right there.
Great, thank you very much, Dr. Macharia. Thanks for that.
Let me stop.
On a very rare case. I'd like to now invite Professor Fagan, and perhaps after that, we're also quite fortunate to have Professor Hill, who's a pathologist, join this meeting. Professor Fagan, please, perhaps some comments from your side to begin with.
Well, Ian, thank you very much. That's really an excellent presentation of a very unusual case. I mean, I can only recall having had 2 adenoid cystic carcinomas of the larynx in my career, and and they really are rare. I guess the only 2 issues here perhaps that struck me. The first one is that we would always give adjuvant radiotherapy afterwards, so we can maximize our local regional control due to the perineural invasion that you referred to. And the second issue is in a fit patient, I can't remember what this patient's age was, but do you think this patient might have been a candidate for a supraglottic or a supracricoid laryngectomy?
Okay, now to answer your first question, since actually we found lymph nodes in level 2B for this particular patient bilaterally, so we might, depending on what the histology shows, we'll decide whether we'll take for radiotherapy, but I do suspect we shall take for radiotherapy as well. Number 2, where the tumor was sitting, it was actually supraglottic. However, looking at the facilities that we have here in Machakos, I mean, we're only 2 surgeons. This would have been a candidate, you're very right, for supralaryngeal, a supralaryngectomy. However, due to COVID and the other things, we elected on a total laryngectomy. We talked to him profusely about it, and he did accept it. But yes, that was an option available if we were able to.
Great, thanks, Ian. Professor Hill, any comments from your side?
Yeah, good morning, everybody. Well, adenoid cystic carcinoma is very much in the focus of pathologists these days. There's actually two issues that, or three nice breakthroughs that we've had with the diagnosis of this lesion. First of all, we've been able to find that it has a particular, what do you call, footprint in terms of a genetic modification. So we now know that there is a translocation of a gene called the MYB gene, which actually will fuse with the NFIB gene. And it's particularly true for the adenoid cystic carcinomas of the head and neck and the breast. So this truncation fused MYB oncogene can be detected by fish. So it's in situ hybridization by fluorescence. And that is now becoming quite a standard test for salivary gland and other salivary gland-like carcinomas of the head and neck. So this transfusion, or this translocation of the MYB gene, together with the fusion of the transcription factor for gene NFIB, actually now offers not only a diagnostic window on these lesions, but also perhaps in the future targeted therapy, because this gene is obviously now known, and it would be, and I know that there are trials in existence at the moment that look at targeted therapy for MYB gene fusion or MYB gene expression in adenoid cystic carcinomas. There's also an antibody that's now available against MYB protein. So we haven't got this one in South Africa as yet, but it will make the diagnosis of immunohistochemistry on histology a lot easier by using the MYB gene, because it's pretty specific in the context of the type of morphology that one would expect for adenoid cystic carcinoma, especially for the, I would say, the solid variant. And then the other one is that in immunohistochemistry itself there's a little bit of breakthrough by looking at a panel of P60 and P40. Now P60 and P40 are both expression, so P63 and P40. They're both tumor suppressor genes, whereas P40 is a subgene of the P63 family. And there's now a panel available that we can look at P40 and P63 expression in order to distinguish adenoid cystic carcinoma from your polymorphous adenocarcinoma, which actually makes life a little bit easier when we struggle with the differential. And that's it from my side.
Great, thank you very much, Professor Hill, for those comments. I'd like to now maybe perhaps also invite Dr. Chege Macharia once again, just for his comments on the management of this kind of patient in Kijabe Hospital, which is also in Kenya, perhaps also commenting on Professor Fagan's comment on the option of a partial laryngectomy.
Thanks, Tasia. It's interesting, this presentation, I literally had to look back at my records. We had a similar patient in May, only that this patient was 34 and has had same diagnosis, only that he came to us having been bounced off other places because of COVID with a diagnosis of a subglottic pleomorphic adenoma. And he is already completely obstructed, had a trach in place at the time, and we elected to, having done imaging, excise it like an extracapsular excision via laryngophagia. I mean, the surgery went well, but unfortunately, the post-op path confirmed the same adenoid cystic in such a young patient. I agree, and not just for this kind of diagnosis, but pretty much for every diagnosis. I think the more we, as surgeons, learn how to do some of these partial laryngectomies and organ sparing kind of surgeries that still give good outcomes as far as oncology is concerned, I think it would be better. And I think it takes just as much effort to do a total laryngectomy as it would to do some of the other partial ones, sometimes, not always. And of course, we have to keep in mind the resources at hand. But for some, especially if you're doing a vertical hemi, that's actually even sometimes a simpler procedure. So it's something to think about for any patient that would benefit from such. Going forward, I think for most of these kind of settings, such as Machakos, where Dr. Macharia is, oh, and by the way, we're not certain whether there's any real relation between the two Machakos. Discussion for another time. But in those, in those kind of settings, I think, first of all, we're going to keep detecting more and more unusual laryngeal tumors. I also have a young lady, she's just about to turn 20, and she has a laryngeal amyloid. But that's completely destroyed her larynx, and unfortunately we'll have to go for a total laryngectomy. But we're going to keep detecting a lot more of these unusual ones, and as we continue to improve in our settings, again, it still boils down to early detection and, as much as possible, organ sparing or partial laryngectomies as much as we can. It's just so much better for the patient. Thanks.
Good morning. I've just actually realized I've forgotten something quite interesting, is that there's now been a number of case reports where P16 expression has been detected in adenoid cystic carcinoma of the head and neck. And we're not quite sure what the significance of this is. Obviously, it has to be verified by PCR in cytohybridization if this is actually truly related to a human papillomavirus or high-risk human papillomavirus association. But so there's something that we need to have a look out for to see if there's any difference in behavior. But at the moment, we're testing all adenoid cystic carcinomas for P16 expression, and I'll take it for PCR if it's positive. And the other thing is that there are some mimics related to HPV related carcinomas in the head and neck, and there has now been an entity that's been discovered in the sinonasal area where there is an HPV associated adenocystic-like carcinoma, sinonasal carcinoma, that is now being recognized. And I think it needs a little bit of attention if, for example, you get a diagnosis of adenocystic carcinoma of the sinonasal area, which not quite fit the picture.
Great, thank you for those comments, Dr. Chege and Professor Hill. I think we're nearing the end of the discussion for this case. Professor Fagan, any comments, perhaps, or any replies for any of the discussions that are taking place?
Perhaps just a comment on the partial laryngectomy issue. I agree with Chege. I think it's essential that we become experts in Africa at doing partial laryngectomies, because we don't have the option of chemoradiation as readily as they have in many Western countries. And we also often don't have access for our patients to speech prostheses. But selecting a patient for a partial laryngectomy is much more than tumor location. You really have to choose your patient very carefully in terms of their respiratory reserve and their mental capacity. And so most certainly there's a culture we have to develop around this and an expertise. And we also have to obviously get our speech therapists involved, because often the challenge after the surgery is to reinstitute swallowing, and for that we need that engagement. But otherwise, it's been a very interesting session. Thank you very much.
Great. Thank you very, very much for for this very, very fruitful discussions. And Dr. Ian Macharia, thank you very much as well. Any closing comments from your side?
Just thank you for the opportunity to present this case, and I'll actually talk to Dr. Shege about his case as well. Just touch base about this. Thank you.
Okay, great. Thank you once again for everyone for joining us today. Really, as you may have seen in this session, the invitation is present to get interesting cases from not only in South Africa, but from different parts of Africa and indeed the world. So if you or your institution do feel like you have interesting cases that are worth talking about and discussing, please, you can reach out to me. You can email me. My email is on the YouTube channel platform. And we can slot you in. But thank you very much for joining us. Have a lovely, lovely day ahead and a weekend that follows. Take care.